I'm Senator Kimberly Lightford. I am the Majority Leader in the Senate, as well as the Chair of the Illinois Legislative Black Caucus. I am joined by my colleagues, Representative Camille Lilly, Chair of the House Black Caucus, and my good friend, State Senator Andy Menard, Chairman of the Appropriations Committee and a champion of working families throughout Central Illinois. I'm also honored to be joined by these caring hospital officials who you will hear from shortly, one being Mr. George Miller from Loretto Hospital. I have an awesome opportunity to serve on the Loretto Hospital Board for the past 20 years. We have a broken managed care program in Illinois, and it's threatening the very future of our healthcare providers and the patients they serve all around the state. Representative Camille Lilly and I have introduced Senate Bill 1807 and House Bill 2814 on behalf of the safety net and critical access hospitals throughout the state of Illinois to reform managed care and end the systemic abuses that are creating this healthcare threat. Let me quickly update you on managed care system, just so you guys know that we're just not coming with this before you today. It's been an ongoing challenge. Before 2011, Illinois used a fee-for-service program where the Illinois Department of Health Care and Family Services oversaw paying providers a fee for services provided to Medicaid patients. In 2011, we started to transition to a managed care program. Private insurance companies, many of them for-profit companies, were brought in to Illinois to take over Medicaid for two goals. One, to coordinate care for Medicaid recipients, and two, to save the state money. Unfortunately, neither happened. In 2015, 50% of Medicaid was in managed care. Today, it's 67%. Most patients do not know they are in managed care. Hospitals still coordinate all care, yet they're losing out on hundreds of millions of dollars in care coordination fees by collection by the MCOs and state payments each year. We're not saving money. The General Assembly asked the Auditor General to audit the MCOs in 2018 and found HFS did not maintain complete and accurate information in order to properly monitor $7 billion in payments made by HFS to the MCOs in fiscal year 2016. The MCOs, as the others here will spell out, is denying and delay. Instead of coordinating care and services and saving the state money, MCOs get their savings by denying claims submitted by hospitals at an average of 20% statewide, more than 1/4 of the time. We have with us here today pens, I was a little early, that we will be sharing with legislators throughout the Capitol with the number 26 on them, symbolizing the average MCO denial, the denial rate at hospitals throughout the state of Illinois. We invite you each to wear one to show the MCOs that time is up and that their days of taking from those in need to give to the rich is over. Under our previous governor, MCOs operated with no real oversight. Billions of dollars have shifted from patient care to these for-profit companies and their corporate shareholders on Wall Street. Hospitals are suffering. Enough. It's time for MCO reform. I want to now turn it over to Representative Camille Lilly to talk about the damage caused by MCOs. Representative Lilly.
Thank you, Madam Leader, Senator Lightford. You are exactly right. Enough is enough. My district, the 78th District, it stretches throughout the west side of Chicago into Oak Park and the western suburbs. Every week, I hear from different healthcare providers calling about the problems they're having with the MCOs. We have ambulance companies, supportive living facilities, nursing homes, and even hospice providers who are all being denied payments. We want to have reliable, affordable, strong quality health care here in Illinois. The Medicaid program and the Medicare program exist to provide services for the poorest citizens in our state, giving them access to health care. The way managed care organizations have been implemented in Illinois today, it has harmed the most vulnerable people in our state. And it's unfortunate that they are suffering. I see the impact of that MCOs have on safety net hospitals within inner city communities and across the state. Many of these hospitals have no commercial insurance payout to help subsidize the losses incurred for caring for the most vulnerable populations. The MCO health plans are not working for large numbers of Medicaid patients. This fact forces healthcare providers to lay off staff, cut back on services for communities they serve, drop plans to expand and invest in their own facilities, delay payments to their vendors who, which is causing a ripple effect in our economy. I stand with my colleagues today to say clearly we need to support Senate Bill 1807 and House Bill 2814 to stand up for the safety net hospitals and their patients, to stand up for the minority communities who desperately need these hospitals, to stand up for the taxpayers who can no longer afford the MCO's practices in our state any longer. It is time to reform the MCOs. Thank you. At this time, I'd like to bring my colleague, Senator Andy Menard, to share a little more.
Thank you, Representative Lilly, and thank you both to the representative and my dear friend, Leader Lightford, for their leadership on this bill. My name is Andy Menard. I represent the 48th District here in Central Illinois. I want to extend a thank you to Mr. Ken Reed, who's to the far right, who's the CEO of Carlinville Area Hospital, for traveling to Springfield today to help us make the case on why MCO reform is so necessary today in Illinois. It doesn't touch just one part of the state. It touches parts of the state that are in desperate need of not just the health care that's being delivered today, but even greater access to health care. So I represent 6 critical access hospitals in the central part of the state, which are being directly and negatively affected by the state's Medicaid managed care program. Critical access hospitals are essential healthcare providers and economic anchors for rural communities across the state. For example, Carlinville Area Hospital is one of the largest employers, not just in Macoupin County today, but in the entire region. And because of their geographic location in rural areas, their smaller size, oftentimes 25 beds, and a demographic mix of older and more fragile patients with higher acuity, critical access hospitals face unique challenges, including finances and shortages of nurses, physicians, and mental health care professionals. More than 43% of the state's critical access hospitals are operating in the red today, or are very close to being operating in the red. And unfortunately, the financial challenges of these hospitals in rural parts of Illinois have been made much worse by the state's broken Medicaid managed care program over recent years. Our local hospitals are facing unacceptably high claims denial rates. That's why, as both previous speakers said, we're wearing these red buttons. That 26%, by the way, is an average in Illinois. If you dig down into the numbers and you look at safety net hospitals and critical access hospitals, those numbers are even higher. And the situation is getting worse, not better. So we're here today to say enough is enough, and things have to change in the state. The long payment delays are costing hospitals in downstate Illinois millions of dollars when they are already struggling to survive day to day. And the state's Medicaid managed care program, which now covers more than 2.2 million Illinoisans, has failed to realize the promise of care coordination, better patient outcomes, greater efficiencies in our healthcare system, and lower costs. Instead, to date, the program has been crippled by bureaucratic rules, requirements that were never envisioned when the program was put into place, paperwork, processes, chaos, and confusion, putting extreme financial pressure on rural hospitals, safety net hospitals in urban areas, jeopardizing access to care for our most vulnerable populations in Illinois. The General Assembly needs to take action to address these problems this session. That's why I'm supporting and co-sponsoring in the Senate with Leader Lightford Senate Bill 1807, which calls for a comprehensive approach to Medicaid managed care reforms to help our critical access hospitals and safety net hospitals. We need to make sure that managed care organizations adopt common sense business practices to cut down on payment denials and delays for medically necessary care that hospitals are providing in good faith and as part of their mission to serve their patients and communities. Our next speaker is Mr. George Miller, representing Loretto Hospital. Mr. Miller.
Thank you, Senator Menard. I also want to thank Senator Lightford and Representative Lilly for their brave work on this important topic. My name is George Miller. I am the president and CEO of the Loretto Hospital in the Austin community of Chicago. It's the heart of the West Side. We employ over 600 team members, predominantly African American community, with an unemployment rate in our community of 114% higher than the national average. Loretto Hospital patients come from our community. In downtown Chicago, life expectancy there is 88 years of life. But if you take a 20-minute ride on the Eisenhower to exit 23B, life expectancy goes down to 68.2 years of life. You lose 20 years of life on a 20-minute ride. So in that backdrop, we have to take care of those patients in that community who have not had proper health care all of their lives. So most of our employees live in the surrounding community. Loretto Hospital is by far the largest employer in our community. We're the largest depositor at our bank, and more than 75% of our patients are Medicaid. And we have almost no commercial insurance. We provide quality health care to residents on the west side of Chicago who otherwise would not have access to health care at all. Last August, we had 10 patients OD'd on heroin and opioid in our ER within a 2-hour period, and every one of them alive today. They couldn't have made it 10 more minutes down the road without us being there. So we're vitally important, critically important to the mission of healing. Ladies and gentlemen, let me be clear. The Medicaid managed care companies in Illinois are absolutely pilfering our hospital, and in turn our community and the patients we're privileged to serve. The MCO denial rate at the Loretto Hospital is 25%, 1 out of 4. They deny payment for everything because they know we do not have the resources to chase after them. They are absolutely putting at risk the sustainability of our hospital and threatening access on the west side of Chicago. Let me give you a couple of examples. I bought the actual patient's records. We had a patient came into our facility, was very sick, went to the ICU, had a $61,000 bill, and the managed care companies paid us $84.43 because they said that patient, somewhere wherever their offices was, did not need to be in the ICU, was not sick enough and should have been observed. And then they paid us $84. Have an ER patient that came in and had a bill of $3,800 with dementia, and they denied $1. They said that patient did not need to be in the ER. I have others examples, but for the sake of time, I'd like to introduce my colleague, Ken Reed, who will talk more about critical access hospitals. Thank you.
Good morning. I am Ken Reed, President and CEO of Carlinville Area Hospital. Carlinville Area Hospital is a licensed 25-bed acute care critical access hospital that provides a wide range of inpatient, outpatient, and emergency services. Carlinville and the state's 50 other critical access hospitals are essential to rural areas of Illinois. We ensure access to the health care for our local residents, often as the sole provider of the health services in our communities. Because of our location in rural areas, smaller size, 25-bed, and demographic mix, older patients are often sicker and often poor. Critical access hospitals face unique challenges. including finances and health professional shortages. In fact, nearly 40% of the state's critical access hospitals are in the red with negative operating margins. And now, because of unnecessary, burdensome, and unfair bureaucracy that the Medicaid managed care organizations have imposed, the financial stability of critical access hospitals is being undermined. An example we have is that there was a blanket denial of rehab services by one of the MCOs, which dealt with physical therapy, speech therapy, and occupational therapy. They requested medical records, which created an administrative burden on our part and delays in payments. This situation is forcing many hospitals and other critical access hospitals to divert staff, time, and resources away from clinical care to deal with MCOs and jump through numerous bureaucratic hoops to be reimbursed for medically necessary services that we've provided to patients. Critical access hospitals simply do not have the capacity or the ability to take on huge insurance companies, the MCOs. The unfair claim denials and payment delays must stop now. That's why we are urging the General Assembly to pass Senate Bill 1807 and House Bill 2814. Key provisions of the bill include MCOs must pay all hospitals qualifying under expedited provider rules on a schedule as regular as that made to expedited providers under the state's fee-for-service system. MCOs must update the provider rosters within 7 days of all new providers being contracted. Reasonable time to correct errors on non-electronic claims by extending a 90-day period after notification. MCOs must make post-discharge care coordination placement within 24 hours of notification of a physician's discharge order or pay for the days beyond the physician's order discharge date. Carlinville Area Hospital and the state's critical access hospitals greatly appreciate the leadership support of Senator Andy Menard, my local senator, and as well as Senator Kimberly Lightford, Iris Martinez, and Representatives Camilla Lilly, Chris Welch, and Kelly Cassidy for sponsoring these critically important bills that will help critical access hospitals and safety net hospitals. Thank you.
Thank you. Is there any questions?
So this 26%, what can you compare it to, like, say, before 2011, before the switch over to managed care? How many denials were there? And, what was that trend line? Does it trend with the more MCOs that are involved? MCO dollars means that there's more denials?
Well, what I do know is much lower, somewhere between 2 and 3%. I just know that over the years since the MCOs have been enacted, we've tried a number of times to approach them and offer up a opportunity to come to a happy median for hospitals so that they're not forced into closure, and they have just not been able to give us any type of support. And so as conversations have happened over the years, what I've come to realize personally is that reform needs to happen. There's forms that are consistent with one another. When you talk to any safety net president at any time, they all have the same challenges. It's nothing made up. You can go check their records and see the example that Mr. Miller just gave you, $61,000 and receive $83. That's just totally a huge disadvantage to a poor hospital.
What are the denials that are happening? I mean, is it just, they shouldn't have gone to the emergency room, but they did? Is that the denial? What other types of denials are there mixed into that 26%?
They shouldn't have gone based on who?
Well, based on the insurance company. So, I mean, is the insurance company, is that what they're looking at, saying, our
let me have
assessment is this,
Mr. Miller answer that. Or
I'll be glad to answer that. They use a variety. Oh, sure. I'm sorry. They use a variety of reasons. One you just said. They should not have been in the emergency room, but we have a little law in the nation called EMTALA that we have to treat folks who come through our emergency room. They also say you have to have pre-authorization. We get the pre-authorization, and they deny payment on the back end, which is completely unfair. Now, you look puzzled that it happens to us every day. I've got a case right here if you'd like to look at the bill. Can't show you the patient's name, but I can show you the bill where that has happened to us. They're denials because they don't have enough clinical, so we have to send all the clinical. The patient has been discharged from the hospital, and they take another 3 or 4 days to get all the clinical information, and they still deny it on the back end. Or they send it to a third-party person who may take months. Our average payment at the Loretta Hospital, they pay us on average 154 days because of these delaying tactics. Again, the bill I have here for $61,000, the patient was in the ICU. A critical care physician was taking care of him. They said they didn't need to be in the ICU and sent us $84.
Maybe this is a question for either one of you, but could you maybe
Yeah, I get a little
paint us
excited.
a picture or explain to us what it looked like when we had the state's fee-for-service program? You mentioned that the denial rate was in the single digits, but what was it like billing? I mean, how has that changed? Is it more difficult or?
Well, there wasn't the paper chase of denials.
Right.
You file a claim, and for the example I was referring to with the therapy services, physical therapy, speech, and occupational therapy, there is no pre-certification process in place now. So you bill, they request medical records, so then that means you gather medical records to support the physical therapy, and you have to send it in. So it starts a paper chase, as you can imagine, and delay in payment. So that's an example.
So which part of this bill actually addresses the denial rate? I'm looking
All of it. So it's just a consortium. If you put it all together and reform it, it will flow a lot better. So if you look at each bullet, you will find that they interlock with one another, and it would make the process more fair and much more expedited in a timely fashion.
And is there any support for just abandoning managed care and going back to fee-for-service?
Oh, sure. Yes.
You're not introducing that bill?
No, we'd like to try it with the reforms and see if we can work with the MCOs, but I wouldn't discard that coming in the future if that's what's needed. This is a critical issue. Our safety net hospitals and our critical hospitals are critical to healthcare in Illinois, and it's unfair that we have companies, many that are not Illinois companies, that are just running business as usual, unconcerned about the challenges they're presenting at hospitals, and we really don't want them to close. They're providing the health care. They should be paid for the services that they do.
Senator, you mentioned a lot of the MCOs are also like private health insurance companies. So there's a weird circle of the MCOs manage the care. They also get tax dollars to pay for some of this care. But from my understanding, there's also hundreds of millions, if not more than $1 billion, in a backlog of payment going to the MCOs. Is that all part of this equation, the lack of the state being able to pay its bills properly and them having to manage the hundreds of millions of
I'm going to give my
dollars?
little snippet, and then I heard Senator Menard so anxiously want to dive in on that from appropriations. But I know that there were challenges, but even once payment took place and the MCOs began to receive all of the money, they still was not releasing any funds. So I think at this point it's just an excuse to carry on with poor behavior. Senator Menard.
Thank you. So two things, Craig. Medicaid payments are expedited. They're treated separately than other vouchers that are submitted to the comptroller. That's part of what was implemented when MCO, the construct of MCOs was put into place years ago. So that's number one. Number two, I could probably count on one hand, probably one finger actually, the number of times a managed care organization has called me as the chairman of the Appropriations 2 Committee in the Senate and said, can you help us pay our bills? They don't need help. You know who needs help? These two gentlemen right here. They need help paying their bills. They're the ones that provide the health care in challenged communities. They're the ones who are making payroll. They're the ones that are doing the work that, that is critical to communities that are in need. So I don't feel sorry for MCOs. There's a backlog in state government to pay bills. That's a reality. But they're not hurting for money, and they're not hurting to make sure that when everybody gets up every day and goes to work, that they open their doors. These two gentlemen do that every single